Good morning and welcome to today's presentation on tardive dyskinesia. Our speaker today is Dr. Patrícia Ares-Romero, or Dr. Patty, as I will refer to her, and I will start with reading her bio. Dr. Ares-Romero is the President and Chief Medical Officer for Dr. Ares and Associates Consulting. She's an accomplished senior executive and thought leader with vast experience in leading innovative behavioral health initiatives. She has repeated success in building and leading cutting-edge behavioral health care with a deep understanding of strategy. She was responsible for expanding the healthcare offerings in Miami-Dade County with an innovative approach to create a vision for the future of behavioral health. Dr. Ares-Romero is a double board certified, a diplomat of the American Board of Psychiatry and Neurology, and a diplomat of the American Board of Preventive Medicine as a specialist in addiction medicine. She was associate professor of the University of Miami School of Medicine for the Department of Psychiatry and Department of Anesthesiology, Pain Medicine Fellowship. She serves as vice president for the Dade County Medical Association and secretary and treasurer for the National Alliance on Mental Illness. In 2017, during the opioid epidemic, she was appointed by Mayor Jimenez to the Miami-Dade County Opioid Addiction Task Force. She is the chairperson for the Addiction Advisory Board for Miami-Dade County. She also serves on the Health Impact Council for the United Way, Miami-Dade County. There's a ton more that I could read, but I'll be happy to share that in my follow-up email. And with that, I'd like to go ahead and welcome Dr. Patty to talk to us about tardive dyskinesia.
Good morning. Thank you, Catherine. And good morning to everyone. Thank you for having me today to talk about this very important topic that actually now we can treat. So when I started my training at the University of Miami, over 20 years ago, we really didn't talk that much about tardive dyskinesia because we really didn't have ways of treating it. So we knew it existed, we knew it was there, and most of the time what we had to do was just increase the antipsychotic to kind of mask the symptoms. So what is tardive dyskinesia? So we know it's a movement disorder, and it's characterized by uncontrollable movements. They're repetitive and the patient really cannot control them. They're abnormal movements and they can happen anywhere in the body. In fact, even throughout the esophagus and the GI tract, you can have tardive dyskinesia. It's usually persistent. Once you have it, usually it's lifelong. And these movements really disturb patients' lives. They affect how they socialize. They affect, going out in the community. I remember having a patient of mine that, her tardive dyskinesia was so difficult that she had difficulty putting on makeup. And so she stopped going out and really socializing with her friends. So it really can impact. In older individuals, sometimes we see this a lot in nursing homes. It affects their ability to feed themselves or even walk because it can cause unsteady gait. So I took this image from Neurocrine Biosciences, and it really talks about where in the body this can happen. The word comes, from tardive, called delayed, and dyskinesia, called abnormal movements, and that's where the name comes from. Usually it happens within 4 weeks of treatment, but sometimes it takes a little bit longer for these symptoms to come along. And we'll see as the presentation goes on that it can be accumulative, right? So being on antipsychotics or dopamine blockers for a long time can also cause it. Sometimes we see it when the agent is taken away because then it unmasks the symptoms and it becomes much more apparent. There usually has to be a history of using a dopamine blocking agent for at least 3 months. So as you can see, the most common, the way we always think about it, it's the oral facial dyskinesias, right? So it's the chewing of the mouth, jaw clenching. A lot of times there's bulging of the cheeks, there's tongue movements, there's dyskinesias of the tongue. So if you have them open their mouths, you'll see the tongue moving from side to side, lip puckering, frowning. Excessive blinking is very common as well. When it comes to the trunk dyskinesia, there can be pulling of the arms, of the trunk, and of the back. There could be rocking and swaying and rotating of the hips. And this, as you can understand, is very difficult for a patient to actually ambulate and walk, and can lead to falls. Limb dyskinesia, as we see it very often, we call it the piano fingers, where the patient will be moving their fingers. There's a lot of times hyperdistended toes. So that's why we always, when we do a physical exam on a patient, or we do the Ames exam, which is what physicians and psychiatrists and providers do to evaluate for tardive dyskinesia. And the psychiatrist or APRN who is seeing a patient should be doing it at least twice a year, or formal AIMS evaluation, where we actually make sure they take off their shoes, we look at their toes, you'll see this, the spread out toes, and then there'll be a lot of tapping. Again, like I said, it could be anywhere in the body, so that's why it's very important for us to evaluate. We ask them to open their mouths, take out any dentures if they do have dentures, because that could be misleading. So like I said, it causes stiff, jerky movements of both the face and the body, blinking of the eyes, the sticking out of the tongue, the protruding of the tongue. Sometimes they'll be waving without really meaning to, because again, it's this uncontrollable movement. And as you can imagine, it's exhausting for the patients, right? Because if you're constantly moving all day, it's exhausting. When we talk about the orofacial, it's the controlling of the tongue. They stick out their tongue, they're blinking, the chewing, frowning, grunts. Sometimes you hear the grunts, and the puffing of the cheeks. The limbs, wiggling the fingers, we talked about that. Tapping, flapping the arms can also happen, as well as thrusting of the pelvis. And the swaying from side to side, which again, one of my biggest concerns with the older adults is falls, right? The risk for falls, which could be very, very dangerous and complicate any patient. So why do we treat patients, right? And there's a good and proper place to treat patients with antipsychotics, right? So it's not that all antipsychotics are bad. We just have to be aware of the risk versus benefits of treating patients, and also making sure that we are very alert of any side effects. So antipsychotics by a class, very well used for schizophrenia, bipolar disorder. It is sometimes used as adjunctive therapy for major depression, usually when it's treatment resistant, and sometimes in agitation related to dementia. There's some additional risks with that, especially strokes. So that's something that you have to always be very, very cautious with as a physician, and always ask questions. I always tell my patients, and I'm a huge advocate, being part of NAMI, is that we should always be asking questions before they treat us with anything, right? Before any doctor prescribes us anything, we should be asking, well, what should I expect? What are my side effects? And if a doctor really doesn't want to have that conversation with you, it's time to find somebody else, right? Because you are your best advocate. And us, for our patients and our family members, I have a mother who suffered a stroke, and I'm asking those questions, what are we doing? As much as I know, but I want to hear from you. The other thing that people don't know a lot about that do block dopamine are drugs for gastrointestinal disorders. And so stuff for dyspepsia and nausea can happen. Particularly, there's two of them, and we'll talk about that. And why does this happen? Well, they block the chemical in the brain, which is dopamine. Dopamine is a great neurotransmitter. It brings us happiness and, makes us, move in the day. But when it's out of balance, it causes problems. So this helps the cells to talk to each other and makes our muscles move smoothly. So when we have too little, then those movements become out of control. So I just put a couple of samples here that are known, haloperidol, which is Haldol, flufenazine, which have been around for a long time. And the interesting thing is that before, when the second generation, so those are the first generation, right? Haldol, flufenazine, trilofan. The second generation started with Risperdal or Risperidone. We had olanzapine. We have many more right now. But we thought that the second generation really wasn't going to cause tardive dyskinesia like the first generation did. The fact of the matter is it does. These are the ones that I talked about that's sometimes used for nausea and reflux. Things like Reglan and Compazine can also cause tardive dyskinesia if you use it for longer than 3 months on a regular basis. So there's additional risks. So the risk factors for patients are usually if you're older than 50, you have a higher risk for tardive dyskinesia. If you have a diagnosis of a mood disorder, so be it major depression disorder or bipolar disorder, you're at higher risk. Postmenopausal status also puts you at a higher risk, and if you have substance use disorder because of the dopamine shift changes in the brain with substance use. And the treatment risk factors, right? So it's cumulative. So cumulative exposure to antipsychotics is going to put you at a higher risk. History of an acute drug-induced movement disorder. And that what it means is when we're talking about acute drug-induced disorder is, let's say they gave you haloperidol and you had a dystonia or you had a tremor. And then when they took away the agent that caused it, it went away. So if you have a history of that, you're at a higher risk for tardive dyskinesia. Treatment with anticholinergics is also, and dopamine 2 antipsychotics also higher risk factor. So the prevalence by class, and this is kind of like what I was alluding to before, there's a 30% chance of getting tardive dyskinesia with a first generation antipsychotic, fluphenazine, haloperidol. There's a 1 in 5 chance of getting tardive dyskinesia with a second generation antipsychotic, risperidol, olanzapine, quetiapine, Seroquel. One of my biggest pet peeves, and I tell this to everyone is, quetiapine or Seroquel is not for sleep. That's not an indication for it. It's a great side effect. If you're on it for another reason, for let's say bipolar disorder, or you're on it for schizophrenia, then that's fine, right? Because you're being treated for that primary disorder and they're using it secondary gain for sleepiness. But putting somebody at risk with a medication for sleep, just for sleep, this is what we can have, right? So that's where I'm always a little bit more skeptical when I ask them, what are you taking Seroquel for? Oh, just for sleep. Well, that's not a good medication. Let's look for something else, right? Because you're at a higher risk for tardive dyskinesia. And then there's a 1 in 14 chance if you've never had exposure to a first generation and you've just taken a second generation. That's the 1 in 14s, or 7.2%. And the impressive number is that about 600,000 people in the US suffer from tardive dyskinesia. So it's a lot. So there was a survey that was done, and how can, tardive dyskinesia really affect people? And of course, as you can imagine, and like the little anecdotal story I told you at the beginning with my patient, 76% of confidence was affected, self-esteem, self-worth. We've had patients that would tell me, in a nursing home setting, I don't want to go out to the dining hall, right? Because I have difficulty feeding myself, and it's very disturbing. And then also, aspiration as well, right? If they're not swallowing correctly. So swallowing is a big one. That's one of my biggest concerns. Dental impairment, so difficulty eating or chewing. So if we have patients losing weight, we have to ask if this could be a contributing factor. And then, because of the reduced range of motion and joint flexibility, there's decrease in strength. And as we know, as we get older, it's so important to maintain our muscle, tone as much as we can, because it prevents falls and also keeps our calcium where it belongs, inside the bones. So what are the recommendations? So the APA, American Psychiatric Association, had not come out with any recommendations. But in 2020, they did come out and they said that if a patient is suffering from tardive dyskinesia, either moderate to severe, they should be treated with a reversible inhibitor or VMAT2. And also should be considered for patients, even if it's mild tardive dyskinesia, if it's affecting them and it's causing some kind of impairment for them. So, my thing is, if it's affecting you and your quality of life, you should be treated for it. So the FDA did approve 2 medications. One is Ingrezza, venlafaxine, and the other one is Austedo, for the treatment of tardive dyskinesia, which is great because, like I said before, we had no treatment for it. So my attending, when I was a resident, would say, increase the Haldol, increase the fluphenazine. And we were doing a disservice, but we really didn't have anything else. So both of these medications work in very similar ways. They regulate the amount of dopamine flow in the brain in the areas that control the kind of movements that affect patients with tardive dyskinesia. Side effect, they both can cause drowsiness. So usually I dose it at bedtime for the patients. And the other caveat is that Austedo has been shown sometimes to cause depression. So it's something that we should always be very wary about in the patients with Huntington's disease where it was studied, because this has been treated for Huntington's disease as well. So what can we all do? The most important thing is, talk to your doctor. If, you or a loved one or someone is having some abnormal movements, And patients realize it, right? But sometimes they don't want to talk about it because they feel uncomfortable, or like I said, self-esteem, they feel ashamed. Talk to your doctor. How can we make this better? So some of the treatment options, sometimes we can lower the dose of the medication, although it doesn't always work that way. Sometimes when you do lower the dose, the symptoms get worse because again, it's that unmasking of the symptoms. You can add another medication to counteract the effects. Traditionally, we used to add benztropine or Artane, but it really isn't indicated. And as a matter of fact, in the package insert for benztropine, or Cogentin is the other name of it, it says not indicated for tardive dyskinesia, right? So we shouldn't. There is an option to change medication. So if somebody's, for instance, on a first generation antipsychotic, or perhaps on a high dose of risperidone, which mimics like a first generation, we might consider switching to another medication. And if that doesn't work, then we would definitely talk about VMAT treatment. I think that's very important. I didn't realize how quick this presentation was. I could talk more about it. Let me see if I can try. Do you want to see if I can maybe put a video on?
That'd be great.
Yeah, let me see if I can. I try not to mess with this too much because when you do, then my whole screen, I'm not as technically savvy as I'd like to be. But maybe we can do that. 57. So these were patients. Okay. So these were patients that were actually in the study. This is a slide that I borrowed from Neurocrine Biosciences. And he was in a study for tardive dyskinesia. He's 57 years old, and he's been diagnosed with schizophrenia, and that was the reason for his treatment. I hope this works. All right. So as you can see, if we focus on his mouth, look at his mouth. So one of the things we ask him to smile. You see, now you're going to see his feet. I want you to observe. He's going to start moving his feet in a little bit. Okay, they're going to show the face now. Okay, so you see the buccal movements. And the other thing is that a lot of times when a patient believes that being observed, they usually don't do it because they have some restraint, but you'll see it as they relax and you perhaps have them tell them to do something. So there's fasciculations in the tongue when he did that. Now, if you notice, there's like this movement of the tongue. You see the blinking? I mean, he's wearing glasses, a little difficult, but you see the blinking. You see the foot tapping? No, he stopped. Let me show you another one. This is a finger tapping that we do because that when we ask the patients to do this, then they're focused on the finger tapping, and then it allows for the actual movements to come out, right? So you can see her mouth movements. And that's what I was talking about. So it could be as subtle as, and you can see her feet tapping on the bottom. She'll do it again because then that's, and usually you see she's holding her thigh with her hand. We usually don't want that because then you can stop the movement. So what we usually ask them is they have to be with an armrest. So then the hands are by themselves. Let's look at another one. So now we're going to see the mouth again. This is like a moderate because there's a lot of the sucking. And you can also appreciate the blinking in this patient as well. So this one is a little bit more severe because this one she has the truncal dyskinesia. She's not dancing to music. This is just a dyskinesia that she has of the truncal movements. which is very, again, and you know, you put yourself in somebody like this, imagine all day moving like this. You're exhausted at the end of the day because you can't control it. So she has a feet tapping, the mouth, you see, she's holding her mouth. You see, and when they ask her, please release, then she goes ahead and she does it, because of course, you know, they're self-conscious. And I think I might have another one. Let's see, hold on. Oh, this one. So again, the same movements here. You're going to see the feet tapping. You're going to see the hands. And you're going to appreciate the fasciculations on his tongue. We also ask the patients to walk across the room just to see if they have any of the truncal dysmotility that can put them at a higher risk for falls. I had one of a younger man, but I don't think it's on this deck. Yeah.
Well, thank you. Oh, go ahead.
No, what I was gonna say, I'm gonna send them, and I'm gonna look for the other one. I have one of a young man in his mid to late 20s that had significant, and actually he was treated with one of the VMAT2 inhibitors, and he really recovered. So that was very nicely. The problem is we want to prevent it, right? So we want to be able to catch it early on. We want to be able to catch any symptoms that you might see right away, so we can make either change the medication, decrease the medication, because if not, unfortunately, this is a lifelong. So they're going to have to take this medication for the rest of their life, because it's usually non-reversible, which is very unfortunate. And actually in the studies, we saw people really responded to the medication, but once they were taken off the medications, the symptoms returned. So that's why it's so important for us to be alert and know about tardive dyskinesia, talk about it. And if we start seeing these symptoms, to really speak to your provider for next best steps.